name is Pietro Giordano. I'm general surgeon working in the Department of General Surgery in Robert Juan Bravo Hospital of Madrid. So I'm very honored to be invited in this Congress, and I want to thank to the other colleagues who participated and collaborated for the scripture of this manuscript, for this article. So as you can see in the first slide, I'm going to talk about a very rare problem in oncology, pancreatic metastasis from lobular breast carcinoma. It supposes difficulties in diagnosis, and it's necessary to review what can find in the medical literature. So this case report was published in 2012 in Medicina Clinical Practica. And before presenting the case report, I wanted to remark the most important aspect that we have to learn during the presentation. So key points are, first of all, neoplasms that affect the pancreas in a secondary way are extremely rare, unusual. Just the incidence is 3%. So unfortunately, we have no specific radiological or cytological features, characteristics, and the patient present no determined symptoms, two aspects that difficult the diagnosis. So some authors propose surgical treatment as the first line option, but it's important to know that we need to select the patient and with single metastasis in the pancreas. If we choose the surgical approach, we have to know that this technique presents a remarkable mortality and morbidity due to the complex process in the surgery. And every case should be presented in the multidisciplinary committee in the hospital, including oncologists, including pathologists and surgeons, to take the best option, the best treatment for this patient. So as introduction, metastasis to the pancreas from another solid tumor in the literature has the incidence rate ranging 2 to 11%, in particular when we have advanced malignant tumors. So the pancreas could be affected from other tumor in two different ways. First, direct invasion. Nearby organs like stomach, like liver and spleen could affect directly the pancreas. And the second is through lymphatic and hematogenous diffusion vessels, like in the lung and renal cell carcinoma, least frequently colorectal carcinoma, melanoma, leiomyosarcoma, and finally the breast cancer, just like in this case. Everybody knows perfectly that the pattern of the spread from breast cancer include lung, bones, liver, and adrenal glands, brain, and ovaries. But it's curious to observe that especially in the more advanced stages of the generalized disease, in the theory, all organs could be affected by cells, neoplastic cells from the breast. Isolated metastasis of infiltrated lobular carcinoma in the pancreas, just I found only 18 cases in the medical literature. So it's a problem, it's an unusual problem that difficult the treatment. Radical surgical resection may be considered as the best option for the treatment if we have single metastasis and to palliative the obstructive symptoms. Perioperative morbidity and mortality, mainly thanks to the advance of the improvement of the technological technique, prolong the survival today. But unfortunately, today, scientific community has no clear indications how to treat this patient when we have a single metastasis in the pancreas from breast carcinoma. For this purpose, I want to present our case. It's a 47-year-old woman treated of papillary thyroid carcinoma with a thyroidectomy. And in 2015, she presented a multicentric lobular carcinoma of the right breast with lymph node involvement, status T2 and positive and no metastasis. So the oncologist offered to her neoadjuvant treatment with the taxotere, adriamycin, and cyclophosphamide. And after that, right mastectomy with axillary lymphadenectomy was performed. In 2011, skin recurrence of the external region of the right breast. So this data shows that the behavior of this type of the cancer is very aggressive. And I wanted to add that lobular breast carcinoma lost completely the capacity for the adhesion, cellular adhesion each other. So his behavior is more aggressive for this reason. Surgical removal and sequenced radiotherapy to the surgical field was performed to treat this recurrence. And in June 2019, as a result of an elevation of the marker CA15-3, a solitary bone lesion was evidenced in the cranial bone. Local regional radiotherapy treatment was chosen to treat this recurrence. And finally, we arrived in October 2019 when we realized a PET-CT scan showed a hypermetabolic lesion in the pancreatic head, confirmed with endoscopic ultrasound. So we realized a function for pathological biopsy and suggestive of adenocarcinoma of probably pancreatic origin was accepted. And for this reason, the patient was presented in the multidisciplinary committee, and we chose the surgery. Thinking that it was a primary pancreatic adenocarcinoma. This picture shows the ultrasound endoscopy. It's a solid lesion. The size is 18 per 25 millimeters, and we without vascular infiltration. So this was a good candidate to the surgery. But unfortunately, the patient presented after the operation, Whipple intervention, pancreatic duodenectomy, a negative clinical course with appearance of disseminated intravascular coagulation and a multi-organ failure requiring hemofiltration. So during admission in intensive care unit, repeated imaging tests were performed to evidence the collection and no leaking of sutures. We didn't see any surgical problems. On postoperative day 11, no clinical improvement, the patient no neurological response, and realized a CT brain scan that showed a left frontoparietal intraparenchymal hematoma with mass effect leading to the death of the patient. After seeing the pathology report of the surgical specimen, I talked with the pathologist and I transmitted to her the information, the clinical history of the patient, saying that the patient had breast carcinoma. For this reason, the pathologist realized an immunochemistry in the specimen, and the final result was surprising because it was a metastasis of infiltrated lobular carcinoma, which strongly expressed GATA3, a binding protein specific for breast tissue, and positive estrogen receptors at 40%. I think that the crucial point that we have to learn in this presentation that when we realize the follow-up of a patient with breast carcinoma, early detection of new appearance of solid tumor far from the breast in other part of the body, we must investigate it, and with imaging test, and for sure pancreatic ultrasound biopsy is essential. This is the pathologic findings. It's microscopic pictures. The arrow indicates the population of neoplastic cells in the infiltrating the pancreatic tissue, just near pancreatic duct in the asterisk. And here we can see immunochemistry. That is the key of the problem, and it's positive for GATA3, a specific marker for breast tissue. So in the medical literature, pancreatic metastases, as we can see, are extremely rare. Spread to the head of the pancreas is more common than the tail. The incidence of pancreatic lesion as a site of solitary metastasis from breast cancer is very uncommon, less than 3%. Globally, I found just 25 cases of solitary metastasis in the pancreas from breast carcinoma, and 18 were lobular. So I found in the medical literature the two most important biggest autopsies series, one in 1970s, 337 autopsies, patient died of breast cancer, and the gastrointestinal spread was just only 16.4%. And this table we can see the resume the different site in the gastrointestinal tract where we can find cells from breast carcinoma. And another serial better, just including 707 autopsies, pancreatic metastasis incidence was 13%. It's very curious and difficult because 50% of these patients are completely asymptomatic. Sometimes we can see jaundice, pepper mass, and 15% synchronous metastasis have also been described in literature. This is a study from Italy, just similar to our case report. 3 women treated with metastasis in the pancreas from breast carcinoma, and we can see after resection, after surgery, the survival period was more or less 30 months. And how can we diagnose this case? So first of all, we have radiology with CT scan and MRI. Usually hypovascular lesions are likely to connected secondary lesion than primary. But sometimes the lesions are hypervascular. So this is the problem because we need to distinguish with a neuroendocrine and pancreatic cancer. Second, we have the obligation to realize echo endoscopy and for sure biopsy. I think that the most reliable method to confirm the diagnosis of pancreatic metastasis is biopsy. Unfortunately, it does not always allow the differentiation between the primary and the metastatic lesions. So for this reason, it's a very useful organ-specific immunochemistry study with markers, specific markers like GATA3, mammoglobulin, or estrogen receptors, because these markers could help to resolve the conflict. And the increasing serum marker like CA15-3 sometimes can help to resolve the problem to in the diagnostic process, but increased level it is not always significant. So, in conclusion, nevertheless, no established indications for pancreatic resection of pancreatic metastases from mammary origin. We can select favorable factors like single location, no high tumor burden, or long disease-free period. And finally, a part of the surgery, we integrate the treatment with oncology, so with chemotherapy and hormonal blockage. So what can we learn about this presentation? When a pancreatic lesion develops in a patient with a previous neoplasm, the hypothesis of a solitary metastasis in the pancreas should always be considered. The medical history must be analyzed and all assumptions must be included in the diagnostic process. And in the case of solitary pancreatic metastasis, in the absence of multiple metastases, if technically possible, we can realize a surgery to relieve duodenal obstruction and improve survival. The information available shows that in just only selected patients with isolated metastasis of breast carcinoma, pancreaticoduodenectomy, as you can prefer, a weekly intervention, can be performed with an acceptable morbidity and mortality rate. So you have here the entire bibliography, and thank you very much for your attention.